Hello everyone and welcome to our module on normal pregnancy. Let's talk about the way we describe the obstetric history of women. The term gravida refers to the number of pregnancies a woman has had, in other words, the number of times she has been pregnant. And when we say a woman is a nulla gravida, we mean she has never been pregnant, and when we say a woman is a multigravida, we mean she has been pregnant more than once. The term para refers to the number of completed pregnancies that have gone beyond 20 weeks. And often we describe the obstetric history of women by their gravida and para numbers. For example, a woman who is a G1 P0 is in her first pregnancy. She's only been pregnant once, that's the current pregnancy, and she hasn't had any completed pregnancies or births. One thing to keep in mind when using this simple GP system is that multiple gestations count as a single birth. So for example, a mother who has delivered triplets after her first pregnancy would still be a G1 P1 by this system, because even though she delivered triplets, that was a single pregnancy that she carried beyond 20 weeks. Sometimes when we're describing the obstetric history of women, we use a more expanded obstetric history called the TPAL system. When you're using this system, T refers to the number of term births a woman has had, which are births where the child was delivered at equal to or greater than 37 weeks gestation. The P in the TPAL system is for preterm births. These are births delivered between 20 and 37 weeks. And the A is for abortions or miscarriages which occur before 20 weeks. And then finally the L is for the number of living children. So for example, if we had a woman who was pregnant 3 times, she would be a G3 because her gravida number is 3. But now suppose she had had 1 term delivery of a single child, 1 preterm delivery of triplets, which is 3 children, and 1 miscarriage. Well, by the TPAL system, she would be a P1114. The first one is for the term delivery of a single child. The second one is for the preterm delivery of triplets. The third one is for the miscarriage, and then the 4 is the number of living children, which are the singleton child and the 3 triplets. We describe the progress of pregnancy based on gestational age, and the definition of gestational age is the weeks since the last menstrual period. This is really a throwback to a time before we could identify pregnancies by measuring beta-HCG or by using ultrasound. Back in those days, the most reliable tool we had for dating pregnancies was the woman's last menstrual period. And so because of this system, that's where the concept of gestational age comes from, and we still use this today. So since pregnancies are described in terms of gestational age, conception actually occurs at 2 weeks, or about 15 days, prior to a woman's first missed menstrual period due to pregnancy. So just to make this very clear, a woman has a menstrual period, and then about 2 weeks go by until she ovulates. That's the time when pregnancy can occur, and then another 2 weeks or about 15 days go by, and that's when she has her first missed menstrual period. So since we call the last menstrual period time 0, this means that ovulation in pregnancy occurs at time of about 2 weeks, and then the missed menstrual period, which is when some women realize that they are pregnant, actually occurs at 4 weeks of gestational age. And this is in contrast to developmental or embryonic age. When you're reading embryology textbooks, they will talk about conception at 0 weeks and development going forward from that point. Clinically, in obstetrics, we talk about the gestational age where conception occurs at a time of 2 weeks. And based on this concept of gestational age, a baby is born at term if it's born at 37 weeks or more. Preterm babies are born before 37 weeks, and post-term babies are born after 42 weeks. And also based on the last menstrual period, you can use what's known as Naegele's rule to determine the estimated date of delivery. According to Naegele's rule, the estimated date of delivery is the last menstrual period plus 7 days minus 3 months. Pregnancy can be divided into trimesters. The first trimester is usually considered to be weeks 1 through 12, the second from about weeks 13 to 27, and the third trimester from weeks 28 to birth. Different sources may use slightly different cutoffs for the first, second, and third trimester, but these are generally the ranges that people go by. And keep in mind that nothing magical changes in the fetus when it goes from week 12 to week 13. These cutoffs for trimesters are just something we use clinically because there are certain events that we expect to happen in the first, second, or third trimester, and this makes it easier to anticipate those. Let's talk about the diagnosis of pregnancy. This is done through identification of human chorionic gonadotropin, or HCG. HCG is a hormone produced by the placenta. It has an alpha and a beta subunit, but the alpha subunit is the same as an alpha subunit that's also found in luteinizing hormone and FSH and TSH, so it's the beta subunit that's unique. So what we use are antibody-based tests to identify the beta subunit of HCG, and that's how we diagnose pregnancy. There are serum tests or blood tests that require a blood draw. These are the most sensitive method for detecting HCG. They can detect very low levels in the 1 to 2 range, and they can be positive within 1 week of conception. The other option is urine tests, which are easier to perform. They don't require a blood draw. These can detect HCG when the level is in the 20 to 50 range in the serum, and these are sometimes not positive until 2 weeks or more after conception. The level of beta-HCG in the plasma doubles about every 48 hours initially during the early stages of pregnancy, and it should rise at least 60% every 48 hours, and this is an important number because if the rise is lower than this, it often indicates a potentially not viable pregnancy. The peak level is at about 100,000. This usually occurs by 8 to 10 weeks, and then the level declines to about 12,000 by around 20 weeks. There is, however, a wide range of the peak for an individual woman and the level value that ultimately happens at 20 weeks. And so this is one of many reasons that you can't use HCG to determine the gestational age. It's only used for the diagnosis of pregnancy. Most obstetricians measure the HCG level twice at the onset of pregnancy. They want to confirm that it's increasing normally, and then after that it's not routinely measured later on during pregnancy. After a positive beta-HCG test, the next test that's usually done as part of pregnancy diagnosis is an ultrasound, usually a transvaginal ultrasound. There are a couple of important reasons why this is done. The first one is you have to confirm that the pregnancy is intrauterine and that you don't have an ectopic pregnancy. And then the second important reason for doing early ultrasound is that ultrasound is the most accurate method for pregnancy dating when it's done in the first trimester. I told you before that we date pregnancies by the gestational age based on the last menstrual period, but you always want to confirm that dating by ultrasound because ultrasound is the most accurate method. Even very early on in pregnancies, there are gestational landmarks that you can see on ultrasound based on gestational age. Shown on this slide is an ultrasound picture showing the gestational sac and the yolk sac and the fetal pole. You can see the gestational sac at 4.5 to 5 weeks, the yolk sac at 5 to 6 weeks, and the fetal pole at about 5.5 to 6 weeks. But really the way that pregnancies are dated by ultrasound in early pregnancy is through measurement of the fetal crown rump length. This is a zoomed in ultrasound image of a fetus early in pregnancy, and you can see how measurement of the crown rump length is obtained. And this length is used in the first trimester before 13 weeks to date pregnancies because it correlates very well with gestational age. And in fact, measurement of the crown rump length is the most accurate biometric parameter for pregnancy dating. If it's done before 9 weeks of gestation, it dates the pregnancy to about plus or minus 5 days. If it's done from weeks 9 to 13, it dates the pregnancy to plus or minus 7 days. Shown on this slide is a graph that you can find in many obstetrics textbooks. It shows the crown rump length on the y-axis and the gestational age on the x-axis. And you can see that early on in pregnancy there's a very tight correlation, meaning that if you know the crown rump length and use that to estimate the gestational age, it's going to be very accurate. As the pregnancy progresses, the width of this trend line gets wider, meaning that the crown rump length becomes less accurate for dating the pregnancy. And so that's a key point. As pregnancy advances, the crown rump length becomes less accurate. But early on in pregnancy, especially around 8 or 9 weeks, that's when it's most accurate for dating a pregnancy. You can use ultrasound to date a pregnancy in the second or third trimester if no first trimester ultrasound is available. But remember, first trimester ultrasound and the crown rump length is the most accurate way to date a pregnancy, so that's always preferable. The way ultrasound is more often used in the second and third trimesters is to estimate the fetal weight. This is done by using 4 standard biometric markers. The first is the biparietal diameter. That's the distance between the 2 parietal bones of the fetus. Measurement of the biparietal diameter shown in this image on the screen here. You can also measure the head circumference of the fetus, the abdominal circumference, and the length of one of the femurs. And so all of these measurements here can be used to estimate the fetal weight, and that's used for a growth assessment of the fetus. You can compare the estimated fetal weight to the expected size based on first trimester dating, and from this you can decide whether or not the fetus has growth that's normal, restricted, or accelerated. Some other things about pregnancy dating: if a woman has in vitro fertilization, this is a special situation because you know exactly when the embryo was implanted. So in these situations you simply add 266 days to the date of conception. You can also measure the height of the uterine fundus. This correlates with the date of the pregnancy. The way this is done is you identify the pubic symphysis and then you determine the location of the uterine fundus. The number of centimeters above the pubic symphysis of the uterine fundus correlates with the date of the pregnancy. Normally, the fundal height increases by about a centimeter per week. So for example, if the uterine fundus were at 28 centimeters here, then the pregnancy should be at 28 weeks. Some other correlates of the pregnancy dating: the fetal heart tones can be heard with a stethoscope at about 10 to 12 weeks, and the mother will feel the fetal movements, this is called the quickening, at certain times during pregnancy. In nulla gravida women, this is usually 18 to 20 weeks. It's a little bit earlier in women who are multigravida. At each prenatal visit, the uterine fundal height is measured to make sure that it matches the date of the pregnancy. If it doesn't, then that's known as a size date discrepancy. This means a mismatch between the height of the uterine fundus and the known pregnancy dating. There are a number of reasons why this can happen. One is simply due to incorrect dating. If the known pregnancy dating is not correct, then obviously the uterine fundal height is not going to match. But there are other causes of a size date discrepancy that have to do with the pregnancy and the fetus, and these are all assessed by ultrasound, which is the next best test anytime there's a size date discrepancy. If the uterine fundal height is larger than expected, some of the potential causes that you can identify by ultrasound include multiple gestations, macrosomia, polyhydramnios, or a molar pregnancy. If the fundal height is smaller than expected, then some of the things you can see on ultrasound that could explain this include fetal growth restriction, oligohydramnios, or fetal demise. This is a table from the White Coat Companion showing some of the clinical signs and symptoms of pregnancy, as well as some of the common exam findings. Pregnancy is the classic and number one cause of secondary amenorrhea because that always occurs during pregnancy. Early in pregnancy, women often have nausea and vomiting. I talk about this in other videos. This is associated with that spike in the HCG level that occurs early in pregnancy. It tends to get better as the pregnancy progresses. And then women can also have general fatigue, breast enlargement, or mild uterine cramping in pregnancy, especially in the early stages. On physical exam, you can see changes that are related to the fluctuating hormone levels during pregnancy. Telangiectasias are small blood vessels under the skin. Palmar erythema is reddening of the palms. And linea nigra is a line down the abdomen. I'll show you a picture of this in a minute. The cervix becomes softer during pregnancy. This is called the Goodell sign. There's also a softening of the uterus that you can feel on examination of the abdomen. This is called the Ladin sign. And then there can sometimes be a blue discoloration of the vagina and cervix. This is called the Chadwick sign. Here's a couple of pictures. On the left is Chadwick's sign. This is the blue purplish discoloration of the cervix. On the right is a linea nigra. This is a line down the abdomen, very common in women during pregnancy. There are lots of physiologic changes that occur in pregnancy related to different organ systems, so let's go through them now one at a time. We'll start with the cardiovascular system. The major physiologic change in the cardiovascular system is that the systemic vascular resistance falls. This leads to a fall in the afterload of the left ventricle, and it leads to a decrease in blood pressure. So during pregnancy, most women have a lower blood pressure than they have before they became pregnant. The preload to the left ventricle also increases because there's a rise in blood volume associated with pregnancy. So because the preload goes up and the afterload goes down, you get a rise in the cardiac output during pregnancy, part of the normal physiologic changes. And then in addition, the maternal heart rate usually rises very slightly during pregnancy. If women enter pregnancy with valvular heart disease, it's super high yield to know that regurgitation lesions like aortic regurgitation and mitral regurgitation, these are generally very well tolerated in pregnancy, and that's because the afterload falls, and that leads to more forward flow and less regurgitation backwards. Stenotic lesions, on the other hand, like aortic stenosis or mitral stenosis, are very poorly tolerated during pregnancy and can become life-threatening. This is because of the normal rise in blood volume associated with pregnancy. If you have a stiff stenotic valve, that extra blood volume cannot flow past the valve, and it will back up, causing symptoms of heart failure if women have stenotic valvular lesions during pregnancy. In the lungs, the major change during pregnancy is that the minute ventilation increases. During pregnancy, there's more carbon dioxide that needs to be exhaled because of increased metabolism as the baby grows, and the rising levels of progesterone lead to a rise in the minute ventilation. Now remember, minute ventilation is your tidal volume times your respiratory rate, so it can go up either through an increase in the tidal volume or an increase in the respiratory rate. During pregnancy, most of the rise in minute ventilation is by an increased tidal volume. The respiratory rate generally goes up only slightly during pregnancy. Because minute ventilation increases, usually the PCO2 falls slightly in pregnancy to about 30. Normal is about 40. This will cause a respiratory alkalosis. Anytime the PCO2 falls, that leads to a respiratory alkalosis, and the kidneys will compensate by decreasing the bicarb. So during pregnancy, it's normal to have a slightly reduced PCO2, a mild respiratory alkalosis with a small decrease in the bicarbonate level, and the pH is usually normal to slightly increased. In terms of the kidneys, the major change is that the total body plasma volume expands. Blood fills the placenta, which diverts blood away from the maternal circulation. That's sensed by the body, and the renin levels go up. This leads to salt and water retention. So women who are pregnant always carry around lots of extra blood volume. They can sometimes have mild peripheral edema because of this going on. The expanded blood volume increases the GFR, so there's more plasma flow because there's more volume. So you can see a slight decrease in the BUN and the creatinine in women who are pregnant. In terms of blood count, red cell mass always expands during pregnancy. That's because there's increased release of maternal erythropoietin. However, even though the red cell mass is expanded and the amount of red cells is increased in pregnancy, when you do blood testing, you commonly see a dilutional anemia. The idea here is that the rise in plasma volume exceeds the rise in red cells. So even though there are more red cells, there are less red cells per milliliter of plasma, and this leads to a decrease in the hematocrit. So it's normal for the hematocrit to fall slightly during pregnancy because of this dilutional anemia. And because of this effect, it's very important to identify and treat mild anemia early on. We always check a CBC at the first prenatal visit to screen for anemia. Blood volume in pregnancy peaks at about 32 weeks, and this can result in a very low hematocrit if the woman enters pregnancy already anemic. Hypotension when lying flat, otherwise known as supine hypotension, is common in the later stages of pregnancy when the baby gets large. A large baby can compress the inferior vena cava when a woman lies flat. This decreases the venous return to the right atrium and decreases the preload to the left ventricle. This leads to a fall in cardiac output, and that causes supine hypotension. The body responds by raising the heart rate, and this reflex tachycardia is sometimes sensed by women and produces symptoms like palpitations. In addition, women can feel dizzy and even faint when lying flat, and that's all because of the compression of the IVC by the baby. Let's talk about coagulation during pregnancy. So pregnancy is a hypercoagulable state. This probably evolved to protect against blood loss at the time of delivery. Levels of lots of different clotting factors change during pregnancy. In particular, there's more fibrinogen and there's less protein S, and these changes lead to a hypercoagulable state. The fetus also obstructs venous return, and this can lead to sluggish blood flow in the lower extremities, and for this reason, deep vein thromboses are relatively common in women who are pregnant. There's also an increased risk of pulmonary embolism in women who are pregnant. There are lots of changes in the thyroid gland during pregnancy. The major change early on is that estrogen drives an increase in synthesis of thyroid-binding globulin, so those levels climb. And since TBG can bind thyroid hormone, this leads to a rise in the total plasma levels of T4 and T3. So if you look at this graph on the screen here showing the weeks of pregnancy on the x-axis, early on the major change is that the TBG level rises, and that causes an increase in the total T4 because TBG is binding T4. This usually peaks and plateaus around 20 weeks. At the same time that is going on, another process is occurring, and that is that HCG can stimulate the thyroid. Remember what I mentioned earlier, human chorionic gonadotropin has the same alpha unit as TSH, so it can stimulate the thyroid gland. This causes a rise in the free T4 level, which is sensed by the body, and that leads to lower TSH production. So if you look at the bottom of the screen again, early on in pregnancy you have free T4 levels rising because that's when the HCG levels are very high. This causes a decrease in the TSH levels. After about 12 weeks, however, the HCG level starts to decline like we talked about earlier in this video. That leads to a falling free T4 level as shown in green here, and the TSH level goes back towards the normal range. Let's talk about weight gain during pregnancy. So normal weight gain during pregnancy is approximately 25 pounds. And when there is excess weight gain associated with a pregnancy, this raises the risk of a number of adverse outcomes. First of all, the baby can get too large. You can have fetal macrosomia or large for gestational age babies, and this can lead to cesarean delivery. There's also an increased risk of pregnancy-related hypertension and gestational diabetes when the weight gain in pregnancy is excessive. It's also bad if there's below average weight gain during pregnancy. This is associated with increased risk. The baby can have a low birth weight and can be small for gestational age, and there's an increased risk of preterm delivery. Now, even though excess or below average weight gain during pregnancy is associated with adverse outcomes, What has the strongest association with pregnancy outcomes is the pre-pregnancy BMI. This has been shown to be more predictive of adverse outcomes than the gestational weight gain. There's lots of evidence that has shown that underweight women with a BMI below 18.5 or overweight women with a BMI greater than 30 have more risk of adverse outcomes, and this is more predictive than the gestational weight gain and whether it is excessive or under average. So what this means is, in terms of intervention, when you're counseling women, you want to encourage a normal BMI prior to pregnancy, because it is that body mass index they have when they enter pregnancy that has the strongest association with pregnancy outcomes. Shown on this slide is a table of the recommended weight gain during pregnancy for women based on the BMI when they enter pregnancy, and more weight gain is recommended for underweight women when they start pregnancy. So a woman who begins pregnancy with a BMI less than 18.5, which is underweight, can be advised that it's okay to gain a pound per week, up to 28 to 40 pounds total. For women who enter pregnancy with higher BMIs, the recommended weight gain is lower, and women who enter pregnancy with a very high BMI over 30 should gain the least amount of weight during pregnancy, only 0.25 pounds per week, for a total of 10 to 20 pounds. Let's talk about exercise during pregnancy. Generally, exercise is safe. It's associated with a lower risk of certain adverse outcomes like gestational diabetes and preeclampsia and cesarean delivery. Usually the types of exercise that are recommended are low-impact non-contact activities that have very little risk of the woman falling. Women are also usually advised to avoid activities that raise the core temperature, so things like hot tubs or exercising too hard. And then there are certain groups of high-risk patients who are told not to exercise. Some of these are listed on this slide. So women with cervical insufficiency, which I talk about in another video, should not exercise because they can develop loss of pregnancy in the second trimester. Exercise should also be avoided in women with placenta previa, hypertension in pregnancy like preeclampsia, multiple gestation, or amniotic fluid leaks. Shown on this slide is a table from the White Coat Companion showing some of the common problems women experience during pregnancy. I'm not going to go through each of them now, but make sure you read over this table and know it before your board exams and before your rotations, because all of these problems come up commonly. They're relatively straightforward to identify and treat if you just know the information on this table. I'll finish this video by mentioning two specific medical therapies that often come up in relation to pregnancy. The first is NSAIDs. So you should know that NSAIDs are often avoided during pregnancy, although studies have shown that when women do take NSAIDs in pregnancy, the overall risk is relatively low. The reason NSAIDs are usually avoided is because after 20 weeks they can impair fetal urine production, and this can lead to oligohydramnios. In addition, in the third trimester, NSAIDs can close the ductus arteriosus. And then even though we generally avoid NSAIDs in pregnancy, you should be aware that low-dose aspirin 81 milligrams is given for prevention of preeclampsia in high-risk women, and I talk about this in another video. And then GERD and heartburn symptoms are a very common problem during pregnancy, and you should know that antacids are generally safe during pregnancy if not taken in excessive doses. In many cases, antacids aren't enough, and you should know that sucralfate is also safe in pregnancy if antacids fail. And then beyond sucralfate, you can use histamine receptor antagonists and proton pump inhibitors. These drugs are also safe and commonly used in women who are pregnant. And that concludes our module on normal pregnancy.